Dr. Bill Adams, and welcome to Plastic Surgery Channel's newest program, PSC Deep Dive. Today's focus is breast implant ALCL. To sort all this out, our hosts for this episode of Deep Dive are Dr. Caroline Glicksman from Glicksman Plastic Surgery in Seagirt, New Jersey, an assistant clinical professor at Hackensack Meridian University Hospital, and Dr. Pat McGuire in St. Louis, Missouri, who's also in private practice at Parkcrest Plastic Surgery and a clinical instructor of surgery at Washington University. There's really no better two people to lead this discussion, and Caroline and Pat, thanks so much for hosting this, and we'll look forward to a really great discussion with your panelists.
So, Caroline, I encourage my breast implant patients to come in for follow-up every year after their surgery, and I know you do the same thing. In the past year, I've had a couple patients come in and they've seen reports in the media about a new type of cancer that have been reported in the breast of women with implants. Have you heard patients say the same thing, and what are they talking about?
Yeah, I've had some patients coming in. It wasn't a big outcry of patients coming in. There was a news story on Good Morning America that kind of highlighted it. So what we're talking about here is a breast implant-associated anaplastic large cell lymphoma. It is a lymphoma of the breast, but it behaves differently in patients who have breast implants. And there's about 500 cases, a little over that, worldwide right now that have been reported. But you have to remember that's out of millions and millions of women who have breast implants. And we are very fortunate today. We did bring together a group of really great experts who are really on the cutting edge of this research. But I want to ask you a quick question. When you see patients with this type of lymphoma, first of all, why is it so hard to detect the numbers of patients that are out there? And second of all, what are they presenting with?
Yeah, there is a small number of the cases, so it's made it difficult to come up with exact conclusions about the cause, about the epidemiology of it. What we do know is that it usually presents with swelling in one or both breasts. Sometimes there's a lump in the breast involved as well. It seems to be associated with textured surface implants. Fortunately, a highly treatable disease if caught early and treated appropriately. We are fortunate today, the guests we have, because we know a lot more about this disease because of them, and they will share with us the most up-to-date information for women who have breast implants or a woman who may be considering getting a breast implant.
Our first guest is Dr. Anand Deva, who is the head of plastic and reconstructive surgery at McGuire University and the co-director of the Surgical Infection Research Group in Sydney, Australia. Thanks for joining us from across the world.
My pleasure.
We have a couple of questions for you, and really we want to highlight something that it's more, your expertise is more in line with the epidemiology and the etiology of this disease. In other words, what causes it and why are we seeing this disease? So if you can give us a little bit of background, that we'd appreciate that.
Sure. So let me first deal with etiology, I think, in terms of what we think causes it. Like with all cancers, it's never going to be one thing, right? It's going to be a combination of things that go together in a particular patient over time that then leads to the development of ALCL. So we published a unifying theory of ALCL last year. And what we think are that there are 4 factors that go into a patient that then ultimately mix in the wrong combination to then cause the development of this cancer. It's an analogy a bit like an aeroplane, right? So for an aeroplane to fall out of the sky, there's got to be like 10 things that line up that go wrong, and then you have your plane crash. So the 4 factors, very quickly, we think that textured implants are definitely something that is associated strongly, and perhaps exclusively, with ALCL. That's supported by many studies from around the world. So there's something about texture that we need to look at. The second thing, particularly with lymphoma, and this is where I think people get a bit confused, it's not like a regular cancer, right? So regular cancers, multiple etiologies, genetics might be the main driver, but lymphoma is a specific type of cancer of cells that actually fight cancer and infection. So Lymphoma Genesis, as it were, the causing of a lymphoma, is a very unique type of cancer. And so we think that inflammation, chronic inflammation, so the body trying to fight something that it doesn't like, and the immune cells are the frontline cells, something is causing these immune cells to respond to this inflammation with a change, with cancerous change. Now, there is evidence to show that the source of that inflammation is coming from bacteria, but I'll get back to that. The third thing is genetics. So, implants going into millions of women around the world. Why is it that there are some women, very uncommonly, that develop this cancer? So there must be something about the genetic makeup of these patients that falls into the mix. And of course, the biggest factor is time. We all know that it's about 7 or 8 years before this tumour manifests. And so whatever process that's occurring is a long, grumbling process that occurs over time. So I'll get back to bacteria, because that's a lot of work's been done on that, and a lot of work is going on that. Now, I know that there are people that perhaps suggest it's particles or maybe rubbing of the implant against the patient's body that causes the inflammation. They can all cause inflammation, but bacteria are the only things that are capable of producing products, proteins, peptides that can actually talk to lymphocytes. And I think this is one of the key things that we're looking at, right now. What are the products that come off a chronically infected implant that interact with the immune system that are then capable of causing a change in these lymphocytes over time? And it's not in isolation, Carolyn. We have work all around the world, actually historical work going way back, that shows that the various proteins and yucky stuff that bacteria produce over time can cause inflammation and then direct change of lymphocytes into lymphoma. The classic example is a bug called Helicobacter, which infects people's stomach.
Right, so we've seen this before in other types of lymphoma.
Of course. So the path from chronic bacterial infection to lymphoma is not, I'm not saying anything new here. I mean, this is something that's been talked about for years. And in fact, if you get into the science behind it, a lot of detail on how these actual proteins are shed, then bind onto receptors on these lymphocytes and specific classes of lymphocytes, and how those proteins can then trigger over time malignant change. So we think it's the same thing. And why do we think it's so important? Because it comes on the back of about 20 years, and both of you are aware of the importance of preventing infection around implants, because we know now that infection can cause contracture. Contracture, for those of you who don't know, is the commonest reason that we have to revise surgery after implants go in. They become hard, painful, cause deformity. And we've done, and all of us have contributed to this huge body of knowledge that shows that bacteria cause inflammation and fibrosis or contracture. Our link was that in some women, perhaps genetically susceptible, the wrong type of bacteria, instead of going down a path of causing contracture, the path can actually go towards lymphoma. So I hope that gives you an idea of the sort of factors we're talking about. Now, it's hard to be definitive, I think, in this area. A lot more work needs to be done.
Right.
But I think as we stand right now, I think some of us are starting to call it. And it's for no other reason than there is a practical purpose, right? So when we look at texture, for example, we need to ask the question, is this the right textured implant? Should we be using an alternative non-textured implant in this particular setting? And these are questions that I think we all have to ask as clinicians. And that is one way to reduce the risk. But the second thing, of course, and we've been banging on this for a while now, a lot of us, is to be absolutely meticulous about surgical technique when the implants go in to reduce that level of bacterial load. It's a good thing anyway, because we've shown it can reduce contracture. It may also be a good thing in terms of ALCL. We can't really do much about genetics, not yet, and we can't certainly reverse time. So I think of the 4 factors that come into it, these are the modifiable factors. And why do we think it's important for surgeons and patients to be aware of this right now? Because ALCL is a disease that takes 7 or 8 years to manifest. So the changes we make now in our practice will have an impact not on this disease, not today, but in about 8 years. So,
let me ask you, I'm just going to interrupt for 1 second to ask you a quick question. So if it's occurring 7 to 8 years on average after the surgical procedure, is there also a role, and I know you've discussed this in your 14-point plan that you've published, we speak about that, but is there also a role, as Pat and I mentioned, that we follow our patients every year and we advise our patients on the risks, just like we would for like a total joint prophylaxis, for heart valves, for other implantable devices? Is there also an etiology possibly that it's not that that bacteria that was introduced at the time of surgery, but an endogenous spread of bacteria from an outside source that took more years to come on and developed at a later time. So should we be advising patients not just obviously seek out a surgeon who is qualified and follows the plan at the time of surgery, but a lifestyle change, slightly different? What do you think about that?
Yeah, look, I think the whole area of breast surgery, and I've talked about this before, breast implant surgery, there's a lot of emotion that swirls around. I think I've published this thing called the game of implants, right? So you've got the patient in the middle, and then there's a whole heap of stuff that surrounds it. And we've been in the game long enough that, whenever we mention implants or risk or, the whole thing becomes, quite emotional and quite fearful. And of course, it touches on so many aspects of commerciality and regulation.
And politics, correct.
And politics. And so, we've all been in the game long enough to know that it's a difficult area, right? But I think ALCL to me is a signal that's been sent, I don't know from where, for all of us to actually look critically at our motivations in this space and our commitment to patients. So I think, what you say, and is what we've been saying for years now, and in fact, I'm sure both of you do this, and I've done this from the day I opened my practice, is that if I put an implant in someone, then it's my duty of care to see them regularly, advise them. What that frequency is, I guess, depends on what your time and what you can afford and what you're prepared to take as a pay cut, right? But I think that commitment has to be there. I think it's the least we can do. And now with ALCL, on the horizon, I think it's even more important. So it's kind of good to be vindicated, isn't it? That we started this 20 years ago before ALCL, but now, more than ever, patients need us to offer them lifelong follow-up. And it's actually, for me as a surgeon, and a researcher, it's actually quite a valuable exercise to see your own results over time. You can kind of work out, that didn't go so well, and right. Perhaps I can change my technique a little bit, or perhaps this is actually quite a good long-term result. What did I do then, 10 years ago that I should be doing now?
And we're just going to stop you right there for a moment, because we'll continue this in the discussion.
So our next guest is Dr. Mark Clements, who's the Associate Professor of Medicine at MD Anderson Cancer Center in Houston. And Mark, you have been in the forefront in the diagnosis and treatment of breast implant-associated ALCL. We know a lot more about how to diagnose and treat patients with it because of all the work that you've done. So for the audience, what would you tell a woman with implants? How would she know if she had developed ALCL?
Well, first, Pat and Carolyn, thank you so much for having me on today. With regards to a patient, about 60 to 80% of patients will have a large fluid collection developing around a breast implant. About 25 to 40% will have a large mass growing on the chest wall. And about 1 in 8 patients, the cancer will metastasize to their lymph nodes, so they'll actually feel lymph nodes underneath their armpit. In very rare circumstances, capsular contracture, a skin rash has also been described. So really, how would a patient know? Really, any kind of asymmetry of the breast, something unusual that doesn't look right, really needs to lead them back to their physician for evaluation.
Yeah, so that's the most important thing. What should a woman do if her breast implant changes? And if it is a change, is it always ALCL?
Not necessarily. So we've seen this fluid collection develops after a year, and on average 8 to 10 years after receiving a textured implant. We see that if a woman develops that large fluid collection around her breast, only about 1 in 10 delayed seromas are breast implant ALCL.
And so what should she do if she develops any symptoms or any change?
She needs to go back to her doctor, and she needs to specifically have testing for CD30 immunohistochemistry. That's an immune stain. And her physician's going to aspirate or take a needle and draw out some of that fluid and send it for CD30. And it's very important that that test is performed, because without that test, it's really not possible to get the diagnosis. That's the beginning of the diagnosis. So if CD30 comes back positive, it also requires looking at the cells under a microscope and seeing large anaplastic cells. And then the third component is that when flow cytometry is performed, they'll see a single T cell clone. Those 3 components are the criteria by the World Health Organization. It's at that point that the patient has a cancer diagnosis. and they need to have a cancer workup with a PET CT scan. That PET CT scan just makes sure that the disease has stayed around the breast implant, or if it's metastasized to somewhere else inside of the body. And it's critically important that that oncologic workup occur prior to surgery. I think that some physicians out there don't necessarily think of this as a cancer or a disease, and so they don't do an oncologic workup. And that workup is critically important.
Well, that involves staging, like we would stage any cancer. Exactly. So not everybody is going to be at that end stage, but it's not something that we advise a plastic surgeon to just take to the OR by themselves. So that's what you're saying. They need to be sort of directed more towards an oncologist in their area if they're not at a major center, or send them over to a major center.
Yeah, I think a oncology consultation is very important, particularly before trying to do any treatment yourself. The workup is critically important, and I think that it's important for physicians to know that this approach, diagnosis and treatment, has become standardized. And it was standardized by the National Comprehensive Cancer Network, or NCCN. Those guidelines have been adopted by every major plastic surgery society as well as oncology organization. And they specifically define those diagnoses that I talk about, as well as the treatment. So the treatment for about 60 to 80% of patients is surgery alone. And it's surgery to remove that implant, remove the scar tissue around that implant, and any associated masses. And we see for about 3/4 of patients, they don't require any further treatment. For about a quarter, they may require further treatment with either chemotherapy, stem cell transplant, even radiation therapy when surgery is not possible. And so in an ideal situation, most patients are curative. However, unfortunately, I think that when we see that physicians don't know about this disease, or patients delay their presentation, or they're not treated appropriately, we can get some of the more advanced cases and even fatalities rarely.
So let me ask you something. As when it comes to physician and patient education, could you talk a little bit about, what the societies are doing or industry is doing? Because that's really the key here. Obviously, if we find patients early, as you said, as it is right now, 3/4 of these patients require surgical procedure, capsulectomy, that's to take out the capsule and to remove the implant, and they're basically cured. So that's great news. Our problem is always, like in any type of cancer, it's just lack of information. So what are you doing, or how are you involved? Do you have any information for us to tell us what the societies are doing, the plastic surgery societies are doing, or industry?
Sure. So the approach is multifold by the society. One is to empower physicians and also to empower patients. So for physicians, you're going to see panel discussions at nearly all of the major societies throughout this year. Also, too, there's going to be a focus on understanding the diagnosis and treatment. That was in the Aesthetic Surgery Journal last year, a review article demonstrating the evidence-based approach of NCCN guidelines, and you'll see it in the PRS Journal this April in a CME article on the diagnosis and treatment. Also, in addition to that, there's websites that are available. There's the Profile Registry, which is a prospective registry. It is a registry with the American Society of Plastic Surgeons and the FDA to track these patients and give granular, detailed information back to physicians so that they know what to look for. You're going to see a blitz of manuscripts come out between April and June in surgical oncology, lymphoma oncology, pathology, all demonstrating appropriate approaches to this. And then with regards to patients, we've really tried to empower them so that if their treating physician doesn't know too much about it, maybe the patient will. And that includes flyers that demonstrate what to do if you now have a delayed seroma, as well as what to do if you've been diagnosed with breast implant ALCL, what to ask for test-wise in both of those scenarios to make sure that they have the guidelines and they can have that discussion with their physician.
Anything else you want to add, Mark?
I think one question that I commonly get from patients is they don't have any symptoms, but they want to rule out or just make certain that they don't have this disease.
That's a good question.
And I think that that's important to be reassuring to patients that if they have no symptoms, there's no real way to test for it. There's no fluid to aspirate, to send off. And so no societies recommend screening of any sort. However, it is important for women to just know their own good breast health and their own physical exam and to know any asymmetries. While I talk about large fluid collections, that's very obvious. Some of the other ones can be much more subtle. Just an enlarged lymph node underneath the breast. It might not be this disease, but they need to go back to their doctor and they need to have that evaluated. Just as similar as an unexplained rash or just any asymmetry of the breast. It can be quite subtle in some patients, and so they do need to go back and have their discussion with their physician.
It's a commitment to the patients, and that's what we try to encourage. I encourage my patients to come back every year to every 2 years, and you learn a lot. You learn a lot about how well you did as a surgeon, but you also educate those patients when something new comes out, when something to look for. As your patients reach the age of 35 to 40 and they start getting their mammography, we're telling them how to get better mammograms, when to ask for an ultrasound, and specifically what to look for if something changes in their breast, and to tell them we're just a phone call or an email away, so they know to come right back to us. Because like you said, the earliest detection, like any cancer, is the one that saves lives. So that's
Right.
great.
I completely agree.
Our final guest is Dr. Steve Teitelbaum. He's an associate clinical professor at UCLA, and he's in private practice in Santa Monica, California. So Steve, if a patient comes in to see you for breast augmentation or reconstruction, what do you tell them about breast implant-associated ALCL?
The first thing I have to do is establish whether they'll be better off with a textured implant. I don't believe much in the advantages of textured round, but there's no question that a textured anatomic implant has a big advantage. And among those, I think the 410 is much better in creating and preserving shape than the other manufacturers. So that means that if I'm suggesting an anatomic implant, I'm suggesting BIA-ALCL. So now we have a choice between a smooth round and a BIA-ALCL. So the first thing is determining, well, what are the advantages? That's the first part. And then I have to discuss the BIA-ALCL with them. And I usually say, look, there are 4 trade-offs of having a teardrop implant. It's firmer, it's more money, it can rotate, and there's this ALCL. And it sort of depends upon the patient how I present it. I'll say there's this rare risk of this lymphoma thing, but it's not really a lymphoma because most of the time it's benign, but there have been a few cases of people where it's progressed to death. And I said, I could explain it to you and talk to you about it for as long as you want. But at the end, it goes down to this. You tell some people that the risk is 1 in however many thousands, and some people say, oh, that's so rare, I want the implant, doesn't matter. You tell the next patient the same thing, told the same way, and they're lymphoma? OMA world? No, it doesn't matter. There's no cosmetic advantage that would want me to do if it had a 1 in a million risk. So that's my spiel.
What would you tell a woman who already has a textured implant she should do in regards to ALCL?
I'd say, well, first of all, is there anything about it you would like to change? Bigger, smaller, softer, different shape, right? So if you have another reason to do surgery, this may be enough to push you over the edge. But if the woman says she's 100% happy, I would say to her that she still has a very small chance of developing even the most benign form. And I would probably tell her it's about 1 in 3 or 1 in 4,000 implants, okay? And she has 2, so then her risk could be maybe 1 in 2,000 of developing it. But if caught right away, most oftentimes it's as treatable as if someone has just a regular accumulation of fluid or scar tissue. But that a few people could sneak through and have a terrible disease, and the chances of that, no one knows the number. I would shrug and say 1 in 40,000, 1 in 50,000 to sneak through and end up with something bad. So that's the way I would say it.
I'm going to ask you a quick question. We usually would see our patients every year to 2 years. You follow them over the years. With this diagnosis of ALCL lingering out there, you just said you wouldn't change an implant before, a patient had another reason to change it. With knowing that the etiology now, it's somewhere between maybe 8 and 10 years, is it pushing you a little bit further, a little closer, I should say, and saying, you know what, your implant is now 7 or 8 years. Would you consider changing it? Instead of with the typical 410, if they look beautiful at 10, 11, 12 years, you wouldn't even think about it. Does it change the conversation a little bit that maybe we could change this implant out because we're getting closer to those years when we're seeing this disease?
It's a good question. And my practice is a little different than yours. I don't call everybody back and ask them to come in every other year. I don't know how you can do that. You must have a few thousand patients. So if you have 3,000 patients coming in every other year, that means you're seeing 1,500 patients a year. You're seeing 30 old patients a week. I don't know how you do that. But at any rate, I only see people if they're back with their breasts for a reason. And if there's a reason, then you'd be reoperating for that reason. If it's a patient who has specific anxiety around their implant, then that's its own kind of story. And I have reoperated now on 2 people since the New York Times story, where they just had concern about it. So at the same time, they changed size, they did another procedure. So I think it's not a cut or dry, only one reason kind of thing.
Anand, what do you tell your patients who are considering having an implant?
Well, I think once again it goes to what Steve and Mark actually say, is you've got to really tailor the implant's anatomy to the choice of implant. And I'm a bit like Steve. If I'm going to use a textured implant, it's only because I want the shape. I don't think there's an advantage for using a textured round implant, really, per se. And then I think you have to inform them of the risk. I think that risk of ALCL is something I think, and certainly Mark and I can speak to, because we've seen, since we both published in this area, the risk, becoming higher and higher. So initially it was 1 in a million, then it was 1 in 300,000, and the number just keeps getting smaller and smaller. And I think that's a reflection of the fact that to collect good prospective data after implants have gone in is really, really difficult. We published work on a numerator-denominator type of calculation where we think we have all the cases in Australia and New Zealand, the denominator being the number of different types of implants sold, and that does show a risk that is higher for implants like BIA-ALCL, which have a higher surface area. That's a theory we're exploring, and we'll have some more to publish and speak about that this year. But then you go to other countries where the numerators and denominators are probably not as accurate, or perhaps more accurate, and the number will change. So I think it's best to talk about a range. So if I'm going to advise someone on risk, I'll say, look, the risk for textured implants sits somewhere between 1 in 3,000 to maybe 1 in 10,000. The risk for smooth implants alone at the moment we think is 0. And then I weigh the pros and cons exactly like Steve talked about, and you tailor it to the patient. It's about their ability to accept risk as much as yours. And I think
perceive risk, exactly.
Yeah, exactly, and understand risk. So I think some people, even if they don't understand it, they want 0 risk, and we know life is not full of 0 risk, really. So it very much is an individual patient to doctor type conversation.
I do think that it's important that when talking with a patient, you never use the word benign. I think that this is a cancer, and we do need to use the correct word. So benign would be like a lipoma. Some physicians have argued that this might be a lymphoproliferative disorder in its very earliest stages. Even a lymphoproliferative disorder is a malignancy. It's not referred to as benign. So I would hesitate in using any kind of words like benign. And also, too, even in its earliest form, when it's only in the effusion, while that is straightforward to treat, I wouldn't say that it's as treatable as a minor complication. This still subjects a woman to a cancer diagnosis, oncologic follow-up, 2 years of PET CT scans, as well as recurrence rates that are real. We look at about 60% of these patients have received chemotherapy. 45% have received radiation therapy. So while we do know how to treat it, it's not exactly as simple as a hematoma or something else like that.
Mark, I want to challenge you on that a little bit. You could say that a lymphoproliferative disorder is not benign, but when patients have a seroma-only disease, it's not an anaplastic large cell lymphoma. We know what an anaplastic large cell lymphoma is, and that's a misuse of that term.
So right now, it is an anaplastic large cell lymphoma by the World Health Organization, by all oncology associations, as well as we believe that after treating 50 patients at MD Anderson, and that's also the thought at Memorial Sloan Kettering, I think that it's important for us to look at the effusion only and to say, is this potentially an early form, an in situ phase, maybe a transitionary phase? It may give light to understanding the pathogenesis. However, we don't know that fluid collection happens to be that one that's only isolated to the fluid. We don't have a way to say that that's going to be the one that doesn't spread or that it doesn't progress.
But it is truly, but it is truly benign in some patients. It is truly a benign. If you're doing just a removal of the fluid and the capsule, and you have a cure rate in those patients of almost 100% or 100%, then that is really not a cancer. Yes, there's follow-up and surveillance, and they're listed and they're registered, but then that's basically a benign entity for those patients. And that's where I think this language of lymphoproliferative versus saying that somebody has a mass that has to be treated. So there has to be some distinction. Anon,
let me chip in here, because I think perhaps we've got sort of two sides, but I kind of sit, I guess, a little bit more into the middle. And we've both, Mark and I, have studied this disease for some time. I think we're kind of talking about the same thing, right? So the focus has got to be on that early stage seroma-only disease. And once you've got these malignant cells floating around in seroma, the question is, will they stay there or will they get worse? And so that's why we focus, particularly in Australia, at the line where something flips from a benign inflammatory seroma to a malignant effusion-only ALCL. Now, where that line is needs a lot more work, but it'd be a very brave person if you've got ALCL to say, you know what, I'm just going to sit and watch and see what happens to you, because you're really, by that stage, we just have no idea which of those patients is going to perhaps stay at the effusion-only disease. Some might actually go backwards and actually become benign seroma again. It might be a slightly wavy line, but we do know for a fact that some of those patients go forward.
Actually are going to be, continuing this discussion. We have Dr. Marshall Caden from Providence, Rhode Island, getting onto the call next week. So we're going to be continuing, and he is actually a T-cell lymphoma expert for over 35 years. That's really where his research is going, to sort of say, where does this flip? Where do we see a change between the benign seroma with then some atypical cells and then the progression on? So we are going to continue this discussion next week.
So the bottom line for patients is follow up with your surgeon. If there's any change in your breast, it's not something to be ignored. And we hope that Mark and Anon and Steve and Marshall, who'll be talking next week, keep up all the research and all the discussions so that we keep moving forward and find out the causes and the absolute treatment on this rare disease. So thank you, everybody, for joining us.
Thank you so much.
Thank you.